Hello, everybody. Here's a quick and unedited version of my lecture on digoxin and antiarrhythmic agents. Now, heart rate is controlled by a number of factors. Specialized muscle in the heart, a powerful conduction system that's influenced in part by parasympathetic and sympathetic activity. Now, there's a small amount of tissue in the heart called the sinoatrial or the SA node. As I mentioned, it's controlled in part by the autonomic nervous system. Cholinergic nerve endings near the SA node are going to react to acetylcholine, and that's going to inhibit impulse formation. It's going to inhibit the electrical conduction that helps to control the contraction of the heart. Sympathetic system influences will involve nerve fibers that release norepinephrine, and that's going to speed up the heart rate. Now, when the heart rate speeds up, rest periods between contractions will be reduced. And I'd like you to remember that because we're going to talk about that again a little later. Anyhow, back to the sinoatrial node. I mentioned it's controlled in part by the autonomic nervous system. The cells of the SA node are unique. They are capable of automaticity. They can generate an electrical charge on their own. Term you've used before, action potential. This action potential moves from the SA node to the atrioventricular or the AV node, and that coordinates atrial and ventricular activity. Action potentials cause heart muscles to contract and push the blood out. In order for the heart to pump effectively, both atria need to contract at the same time. In addition, both ventricles need to contract at the same time. Now, after the ventricles depolarize and emit that electrical charge, there's that rest period, the refractory period, where they relax. At this time, repolarization occurs in preparation for another electrical charge. Now, we talked about hyperlipidemia, we talked about hypertension, and both of these disease conditions can result in heart failure. Heart failure can also occur after a myocardial infarction or renal failure. There are changes in the heart that occur in response to heart failure. The muscles of the heart become weakened. This is sometimes in response to an increased fluid volume or an increased preload, the amount of blood entering the ventricles, or increased afterload caused by an increased resistance for which the heart has to pump more strongly in order to push blood out of the heart and into the blood vessels. After an MI, the muscles of the heart are destroyed, right? So they lose their automaticity. They're replaced by scar tissue. The heart is no longer able to pump effectively. Blood begins to back up. As a result, there can be insufficient blood to meet the needs of the body. Now, when the heart muscles weaken, they can affect the left side of the heart or the right side of the heart, or even both. When it affects the left side of the heart, the blood will back up into the lungs, resulting in shortness of breath, a cough, adventitious breath sounds. When it backs up to the right side, from the right side, it'll back up into the peripheral regions, causing peripheral edema. Because blood isn't pumped effectively, the body compensates by increasing heart rate, but that results in an incomplete emptying of heart chambers. Remember, uh, there's usually a refractory period. During this refractory period, the chambers of the heart once again fill in preparation for the next contraction. When heart rate increases, those chambers of the heart can't fill. So there's not enough blood being pumped out with each contraction. Okay, because of these changes, the heart is remodeled. The heart enlarges. So there's the indication here for the use of cardiac medications. Cardiac medications can change the force of cardiac contraction, help to ensure that more blood is being pumped out with every contraction. They can also change the rate of impulse formation, slow it down, and affect the electrical impulses that surge through the myocardium. Cardiac glycosides have positive effects and have often been the mainstay of treatment of heart failure and atrial fibrillation. Digoxin, it has been the mainstay for years. Not used quite as much here in the United States, but a more extensive use in Europe. It exerts a positive inotropic effect. It increases the force of contraction. Digoxin also has a negative chromotropic effect. So it decreases heart rate. In addition, digoxin has a negative dromotropic effect. It reduces the rate of electrical conduction. It slows down the electrical impulse and allows the atria and ventricles to work together in a coordinated fashion. The action of cardiac glycosides, they inhibit an enzyme, sodium potassium ATPase, which increases sodium levels in the heart. The increase in sodium leads to an increase in calcium, and it's that increased calcium that causes the release of proteins that are responsible for muscle contraction. The proteins also prolong that rest period, allows more blood to fill in the ventricles in between heart rate. Ultimately, the effect is that cardiac output is increased. Now, as far as med administration of digoxin, clients are sometimes given a digitalizing dose, an increased dose, until the tissues are saturated. All right, this is to quickly bring a therapeutic level. Can be done quickly when given IV in the hospital. PO takes about 7 days. At this time, there'll be frequent monitoring of digoxin levels because there is a very narrow therapeutic range. Normal range is 0.5 to 2 nanograms per milliliter, not milligrams, not micrograms, nanograms per milliliter. And any change in doses at this time after digitalizing, during digitalizing, I should say, are based on the lab results that are obtained. Once the client is brought into a normal range, they'll be followed by maintenance doses. Now, most glycosides tend to cause a gastric irritation, so it's advisable to take them with food. We'll move on to the next slide here. Talk a little bit about the adverse effects of glycosides. I mentioned they tend to be irritating to the GI tract, so it's not uncommon to experience nausea, abdominal cramping. Our big concern is with glycoside toxicity. Remember, please, that there is a narrow therapeutic range. Often, the very first sign of toxicity is anorexia. Client complains they just haven't had much appetite lately. Don't let that go. Follow up, assess further, check to see if there are other signs of glycoside toxicity that are presenting. These would include nausea, vomiting, and abdominal pain. Often, often there are visual disturbances as well. Diplopia is double vision. Visual disturbances include clients seeing halos around objects, maybe a yellow-green tinge or blurring. EKG is taken, and the client might demonstrate a bigeminal rhythm. It's a normal heartbeat followed by a tiny extra beat. It shows up on EKG. Consider that possibly there are risks for toxicity, and these risks increase with hypokalemia. So any client also taking a diuretic that possibly depletes the body of potassium should be assessed. Renal impairment. Consider the IV doses. Perhaps we are saturating those tissues too quickly. So severe cases, when those digoxin levels get to extreme amounts, are treated with Digibind. Digibind is derived from sheep serum. Digibind interprets digoxin as an antigen and forms antibodies to the digoxin. They may need to be pre-medicated before administration of Digibind with diphenhydramine to help prevent any immune responses. Digibind works quickly. When administered IV, it can work within 60 seconds. A couple other points I probably should have made before talking about Digibind, although Digibind is important. I'd like you to know that. If you suspect glycoside toxicity, you assess further. Look for other signs and symptoms of toxicity. Look at the EKG. Get potassium and digoxin levels in a lab draw. If necessary, the client would be given potassium supplements. If experiencing nausea and vomiting, administer antiemetics. All right, and then consult with the doctor if the doctor orders Digibind, and generally these are for very high levels. Digoxin levels would have to be above 10 nanograms per deciliter. All right, so let's move on. And we'll talk very briefly about antiarrhythmics. Right, antiarrhythmics given in response to arrhythmias, dysrhythmias, and they can these alterations in cardiac conduction can occur from a variety of conditions. Sometimes stress, sometimes unexplained. They just simply happen and clear up quickly. So stress, hypertension, they can occur after a myocardial infarction where some of these cells capable of automaticity are damaged and replaced with scar tissue, can occur in response to electrolyte imbalances. All right, so these um, antiarrhythmics that we'll mention briefly, some of which you know already, all alter the movement of electrolytes into cells. We don't see them used as widely as we used to. They have decreased in their usage, and that's for a number of important reasons. When used to prevent dysrhythmias, some of them have been found to increase patient mortality. There is also a strong tendency when you're altering the action of one electrolyte to cause a whole new dysrhythmia. They also tend to have narrow therapeutic ranges, so we have to assess that client constantly. Other techniques have also been found to be more effective, like cardiac ablation, where we scar certain tissues in the heart in order to suppress the dysrhythmia, the site where the dysrhythmia originates. So you have sodium channel blockers, procainamide, um, usually replaced lately by medications like lidocaine, and these interrupt sodium from entering myocardial cells, thereby slowing conduction and reducing automaticity, extending that refractory period, right, allowing those chambers of the heart to refill. It's available PO and IV. Multiple side effects are possible. Beta-adrenergic antagonists like propranolol, you've heard that name before. Beta blockers decrease conduction and primarily used in post-MI clients, but they do have their adverse effects: bradycardia, hypertension, and possible bronchospasm because of their effects on beta receptors in the lung passageways. The last two would be the potassium channel blockers and calcium channel blockers. Both have their adverse effects. The potassium channel blockers we have to use very cautiously in heart failure patients. Strong tendency to cause dysrhythmias like torsades de pointes, VTAC, ventricular tachycardia. So amiodarone would fall under this category. Calcium channel blockers we've talked about before. Diltiazem, verapamil, slows that AV conduction, prolongs refractory period. Remember that the calcium channel blockers can have a tendency to cause reflex tachycardia, which can increase the oxygen demand of the heart. So, as promised, a short, unedited, narrated presentation. If I've missed out on anything, I'm going to cover it in our Wednesday Zoom session, and I'll talk to you then.